Hello, everyone. Thank you so much for hopping on today for the FORTE Polyp webinar. We are very excited to have Dr. Duker, FORTE Protocol Co-Chair, here to present on all things polyps for Energy CC005.
All right. So just sort of jumping right into it here. My objectives for this presentation are to really have you understand colonoscopy and pathology reports. And I say, think like an endoscopist. So we're going to go over some common questions that I've incorporated into the presentation. And like I said, I do want to leave time for your questions. Cheryl, I have to thank. She took a wide variety of questions that many of you had submitted previously and others, and sort of compiled them into one document. And I was actually going through that document a lot and using that to build the presentation. So I'm trying to put in what I hope are common questions, concerns into the presentation, but we'll see how good of a job I did. And I may not be a world expert in colorectal cancer screening like Rocky is, but I am an endoscopist. I've been practicing on my own for 6 years and have done, at this point, 1,000, if not 2,000 colonoscopies. So hopefully that makes me an expert endoscopist at least, and I'll work on the ladder as my career keeps going here. So what are we doing during the colonoscopy? So we're obviously doing lots of things, but if we're doing a FORTE eligible colonoscopy or sort of a screening or diagnostic colonoscopy, one of our main objectives is to find and remove polyps. And what you're going to see in a colonoscopy report is a description of the polyp size and features. You're going to see description of a removal method, which we'll get into. And then any pathology, so any piece of polyps that's removed is going to be placed in a pathology specimen container or jar. And then that'll get sent to pathology and you'll have a pathology report as well. And part of the, maybe the art of this is sort of understanding what goes into those reports and what goes into each section and how do you kind of synthesize that information into, what are we really looking for? So just some polyp terminology. These will be found in the colonoscopy report. You're going to see a term called sessile. And in a colonoscopy report, that's going to mean flat. Now, we'll talk about something in a pathology report called a sessile serrated adenoma. A sessile polyp in a colonoscopy report means that the endoscopist said this polyp looks flat. And that's opposed to something like pedunculated, which is on a stalk, which you kind of see in the bottom right. And sessile polyps can be all kinds of things. They can be hyperplastic polyps. They can be tubular adenomas. They can be sessile serrated adenomas. So the word sessile in a colonoscopy report does not tell you anything about what kind of polyp it is. It just tells you that it was flat. And I don't know why they did this. It is very confusing. I remember he was in a fellow, like trying to sort all this out. But in a report, you're not so much worried about the term sessile. Now, what gets, just to throw in more confusion, sometimes you'll see in a colonoscopy report that something is hyperplastic or hyperplastic appearing. That's us guessing. The determination if something is hyperplastic or not is ultimately based on pathology. But sometimes when we're just doing the reports, especially if we see a little tiny thing, it's in the right area, meaning the rectosigmoid, we just say, hey, that looks hyperplastic to me. It looks small. I'm not going to remove it. That is allowed per the FORTE protocol, which we'll get into. But when we say hyperplastic in a report, we're guessing that it's probably hyperplastic, but it doesn't mean that it's for sure a hyperplastic polyp. And then like we talked about, a pedunculated polyp means it's on a stalk. That's a good example there. Many of these are actually going to be too large to be FORTE eligible, but that's a term you might see. Now, what are you looking for in the colonoscopy report? Well, the polyp size is determined by the colonoscopy report. So it's not going to tell you anything about what kind of polyp, but it is the source of truth for what size it is. The pathology report is not a great place to look for size, and I will get into that in a lot more detail. The reason we use colonoscopy is we use our tools that we actually use to remove the polyp as reference points. And then if you do enough of these, like me and my partners, eventually you just sort of get a guess of what size they are. But you can see on in the image on the left side, these are our snares. And I'll have more pictures of these, but these sort of open up around a polyp, and then you squeeze the polyp into it and it shaves it off. Based on the type of snare, and we'll know which kind of we're using, you can see that there are sizes, be it the tip of the snare before it's open, like the widest part of the snare, the very base of the snare, and that really lets us understand what the polyp size is. And the same with our biopsy forceps. These are little kind of grasper tools that allow us to remove polyps. If it's closed, if it's open, between those two, we actually can get an estimation of the size. So a lot of this we're using to tell you what size it is. And for the purposes of FORTE, the size the endoscopist says the polyp is the source of truth for what size the polyp is. You may also see terms like small or diminutive or other words. These are actually all allowed. They are considered to be less than 10 millimeters. This is just some language that we've developed in our field that small really refers to something that's not an advanced adenoma, which by definition is greater than, or is 10 millimeters or greater, or 1 centimeter or greater. And this is actually a very nice paper that was written by one of our steering committee members. I'm seeing a concern that the slides haven't changed. Are you seeing that, Cheryl?
The slides look fine on my end. If
Okay.
you're experiencing any technical difficulties, please feel free to drop off and hop on with the same link to the Microsoft Teams webinar.
Okay, thank you. It's, yeah, we'll see. It's multiple people are sort of mentioning seem to be behind, but they're loading fine here. And if Cheryl, you're seeing them, we'll have to figure this out. Moving on a little bit, so I wanted to talk about some of the endoscopic findings. So this is actually how we take out a polyp with a biopsy forceps. They're opened. You can see the polyp is in the left picture, and the forceps are advanced over the polyp and sort of closed around it. And then the forceps is pulled back, and that just sort of grabs the tissue and removes it. And you can tell here from the image all the way on the right that there's no residual polyp tissue left, which is what you're looking at here. That's opposed to a snare. So a polyp is sort of in pictures A and B there. The picture on the left shows the snare as it's opened around the polyp. And then picture C is a picture of what it looks like when the snare is closed around the base of the polyp. Picture D is actually a picture of the polyp itself, which is actually that kind of red raised part in the middle. And there's actually a margin of resected tissue around it. And then image E is actually the polyp site. So this is actually one of the reasons that the pathology is going to overestimate a polyp size, especially with the cold snare. You're actually going to get a decent amount of normal tissue around the polyp. So a cold snare sometimes will overestimate the size of a polyp on a pathology specimen. This is why we rely on the endoscopic impression of the size of the polyp. And I think this is a very nice example of what you should be doing. You should be taking a little extra tissue around the polyp to make sure it's a complete resection. And then the other thing to note is that in this technique, the polyp just is sort of laying there like in image D after it's cut. And we actually suction the polyp through the scope and capture it in a trap that's behind the scope. What can happen during that process, it can actually break up into pieces. So in this situation, you might have fragments of a polyp, and then you don't get a clear sense of the total size because there's multiple pieces. And it's sort of, when you get the pathology report, it might say something like fragments, and you're kind of like, well, wait a minute, I thought it was one polyp. Why are they reporting fragments? Hopefully this understanding how these polyps are seen, how they're removed, will help you understand what the eventual pathology report says and what to do about it. So whether they're removed by biopsy or by cold snare, they're placed in jars. Now, what is also difficult is there's no standardization about how they're placed in jars. Some people per polyp or even per section, say like the right colon or ascending, the transverse, the descending, if there are polyps in multiple places, they'll kind of drop them off in different jars. Other people will take all the polyps in the whole colon and just put them in one jar. And so you have to know how many polyps were removed on the report, and you have to know how many polyps were put in each jar before you can fully understand what's happening in the pathology report. And this is what we're doing when we're actually reviewing our own pathology, is we have the report up and we have pathology report, and we're saying, okay, I put one polyp in the ascending jar, I put two polyps in, say, the rectum jar, and then I'm cross-referencing that with the pathology to understand ultimately how many polyps of what kind are in one jar versus the other. So that's really, really important. And I think that helps you understand when you're kind of distilling this down. All right, we're going to move on to pathology. So pathology is going to be the source of truth for the histology or the type of polyp. So this is where the final answer is if something is a sessile serrated adenoma, a tubular adenoma, a hyperplastic polyp, or there are some other ones, lymphoid aggregate, juvenile polyp, other things that we'll talk about. Now remember, pathology can over or underestimate the size of a polyp. So I think the very easy answer is colonoscopy is for the size, pathology is for the type. Do not use the report for the type, and do not use the pathology report for the size. And we talked about this. Cold snares can take extra tissue. So the pathologist will say that the specimen is larger than the actual polyp. Sometimes polyps with forceps require multiple bites. So you're going to get fragments. They might say a 4 millimeter or 3 millimeter. Well, that's a 7 millimeter polyp. They were just getting it in fragments. And you also can't reliably add them up either. I made it seem like you can. So really, the colonoscopy report for size, the pathology report for type. Okay. Just to get your mind thinking a little bit, and people are welcome to chime in answers if you feel like it. But there's a 6 millimeter sessile polyp in the transverse colon removed with a cold snare. The pathology report says it's a tubular adenoma, and you can answer for yourself at home when you're playing along. Is this a sessile serrated adenoma or a tubular adenoma? And of course, the correct answer is a tubular adenoma. The fact that they said it's sessile, good. The fact they said it's sessile refers to the fact that it was just flat, okay? The pathology determines the type. There's another one, a 3 millimeter hyperplastic appearing polyp is seen in the rectum, removed with a cold biopsy forceps. In this case, the pathology actually comes back as a tubular adenoma. So which one is this? Is this a hyperplastic polyp or tubular adenoma? And person that chimed in, yes, you're correct. This is in fact a tubular adenoma. So in this case, although the endoscopist wrote that they thought it was hyperplastic appearing, something compelled them to take it out. But the source of truth for type of polyp is the pathology report, and it's going to overrule the estimation of something that may or may not be hyperplastic in an endoscopy report. I think this is less common in practice, but it can happen, and it tests the theory, and it's just important to point out. Okay, this one's a little bit trickier, but I think it comes up a lot. Okay, so this is a colonoscopy report. They're going to say that there are 2 3 to 4 millimeter polyps. And so why is there a range there? Well, if there's 2 polyps, excuse me, one might be 3, one might be 4. Sometimes one will be 2 and one will be 6. And so the range of both polyps will be reported and not just one size. Now we do account for this and you're able to enter this as such when you classify these polyps. So here's 2 3 to 4 millimeter polyps in the ascending colon. They were removed with a cold snare, and 1 2 millimeter rectal polyp removed with a cold biopsy forceps. Now, all 3 polyps are put into one jar, and when the jar comes back to you, you're looking at the report where it says like pathology colon polyps, jar 1 or whatever. It says tubular adenoma and hyperplastic polyp. So the tricky question here is, how many tubular adenomas could the patient have? 3, 2, 1, or 0? And by the way, there are multiple correct answers. I think this is a good example. Getting some answers, I like it. So the answer is 2 or 1, and I'll explain. It's not 3, because at least one of the polyps is hyperplastic. So I guess one concept is a polyp is either one thing or another thing. So because they're seeing some hyperplastic tissue, it means that at least one of these polyps, probably the rectal one, was a hyperplastic polyp. Now, I don't know that, right? But I'm just sort of guessing. And it's not 0 for this. It's like the same concept, but reverse. Because at least one of the polyps is a tubular adenoma. So you can't say that, some tubular adenoma is in there. You don't know if it was 1 or 2. But at the end of the day, we don't know if this is 1 tubular adenoma or 2 tubular adenomas, because it could be that one of the ascending polyps was also hyperplastic. Now, that's less likely, but we really, really don't know. And this is something that's come up, and we think it's accounted for in how you actually classify these polyps going forward. In this particular case, we're not going to know if it's going to be 1 or 2, but regardless, this patient actually would be eligible, because they can have 1 or 2. And even though if you don't know it's 1 or 2, because it's one or the other, they're eligible. So we're going to get into the frequently asked questions section. So this is where I, again, tried to integrate as much as Cheryl sent me as I could. And then we're going to layer some of these frequently asked questions on top of the FORTE inclusion-exclusion criteria. And the whole point that I hope is that you'll become more efficient at determining FORTE eligibles instead of maybe screaming at a pile of colonoscopy and pathology reports all the time. You might still do that, but that's okay. You'll be better at it. So let's talk about prior colonoscopies. Eligible patients must not have a history of a prior adenoma. So if there's any adenoma on any prior colonoscopy, the patient is excluded. A normal colonoscopy is okay. So it doesn't have to be their first colonoscopy. If they had a colonoscopy, say at the age of 45, it was normal, they're told to come back in 10 years, they're back in 10 years, they have an adenoma or something, or two small ones, that could still be eligible. Now, remember too, a prior colonoscopy with only hyperplastic polyps is okay. So that same example, you're 45, colonoscopy, either the endoscopist says it looks like there were small hyperplastic polyps in the rectum or sigmoid, I did not remove them, that's okay. Or they see polyps in the sigmoid or rectum, remove them, and they are hyperplastic, or they actually see polyp further up, say in the right colon, ascending, transverse, and it's confirmed on pathology to be hyperplastic, those are okay. So an adenoma on a prior colonoscopy excludes you, but a hyperplastic polyp on a prior colonoscopy, assuming it was less than a centimeter, is okay. Now, this is very common. What if there's no report after you've had some of a prior colonoscopy, after you've had some due diligence in trying to find it? What we think is that if they were told it was normal, or they were told there was no adenomas, this is okay. If they're not sure what they found, right, the patient's not sure, but they were told to come back in 10 years, that's a really good surrogate that it was either normal or only hyperplastic polyps, because otherwise they would have been told to come back sooner, probably 5 years, sometimes 7 years. A history of benign polyps, I would actually consider to be ineligible because benign polyps, by definition, could be adenomas. So in general, if there's no prior report, if they were told normal, no adenomas, or told to come back in 10 years, we're generally considering this to be okay, but not if they were told they just have benign polyps, because that could be adenoma. Okay, what about number of polyps? We kind of touched on this. Eligible patients will have 1 or 2 less than 10 millimeter adenomas on their qualifying exam. The pathology of a sessile serrated adenoma or a tubular adenoma are both considered okay. So if you had 1 sessile serrated or 1 tubular adenoma, that's fine. You could have 2 of each kind, or you could have 1 of each. As long as there's some combination of the 2, as long as there's no more adenomas, and as long as the adenomas are less than 10 millimeters, you're good. We talked about this, but I think it's worth discussing again. Patients with additional hyperplastic polyps that are less than 10 millimeters are okay as well. So that means if they're removed and the pathology report says they're hyperplastic, that's okay, as long as they were less than 10 millimeters. Or if the endoscopist says, I think I saw small hyperplastic polyps in the sigmoid or rectum, I didn't remove them because they looked hyperplastic to me, that's okay, as long as it's sigmoid or rectum. If they said, I saw hyperplastic polyp in the ascending colon and I left it there, that would actually not be okay. And the reason for that is because the chance that that's actually a sessile serrated adenoma is higher, and it is not standard of care to leave a polyp that's further up, so to speak, than in the rectum or sigmoid that's hyperplastic. Those we're supposed to all take out, and if you don't, that's actually considered, not a complete colonoscopy, at least a completely resected polyp colonoscopy. Okay, so moving on to eligibility. This is a question. There are 3 2 to 5 millimeter polyps in the sigmoid colon. They were all removed with a cold biopsy forceps. And the pathology says that they are fragments of a tubular adenoma. So the integrated question here is this patient FORTE eligible? Yes or no? In this case, it's no, because this patient had 3 polyps, yes. And 3 polyps that all are some fragment of tissue, they could be 3 tubular adenomas. Is it possible that there were 2 tubular adenomas and 1 hyperplastic polyp? Yes, but no hyperplastic tissue was reported. So it's less likely, and we just don't know that. So we have to assume that this could be 3 tubular adenomas and the patient would be excluded. I will go back quickly to answer a question. So there was a question if the patient has 2 serrated adenomas and 2 tubular adenomas within the size limitations less than 10 millimeters, would that be okay? Well, if they had both, if they had 2 serrated, sessile serrated adenomas and 2 tubular adenomas, that would be 4 polyps and they would be excluded. So the total number of polyps has to be 2 that are less than 10 millimeters. It can be any combination, but it has to be 2 total. All right, great. Let's keep going. In this case, there are 2 5 to 7 millimeter polyps in the ascending colon. They are removed with the cold snare. Additionally, hyperplastic polyps are noted in the rectosigmoid colon. I didn't mention this, but let's say they were small, or they were all less than 10 millimeters, but they were not removed. The pathology of the ascending, because that's the only pathology you have, says sessile serrated adenomas. Is this patient FORTE eligible? Yes or no? You guys got it now. So in this case, yes. The hyperplastic polyps in the rectum and sigmoid, if they're small, do not exclude you, and they have 2 sessile-serrated adenomas confirmed on path, both less than 10 millimeters. Good. All right. So let's talk about complete excision. So in part of the protocol, it says that it must be a complete colonoscopy with complete removal of every polyp. So polyps are considered completely removed based on the colonoscopy documentation. So the colonoscopy, it might say nothing. It might just say removed. It hopefully says completely removed. But if you see anything like incompletely removed or partially removed, that's a red flag that they're not going to be eligible. Now, remember, we talked about this. Fragments may be reported in pathology, and that's okay because they were either removed with multiple forceps bites, or maybe it got broken up when it went through. So the fact that there's fragments does not mean it was, does not translate directly into the removal. The endoscopy report will tell you if it was completely removed, and I would say in a vast majority of the time for small polyps, the answer is yes, they were. Unless there's some documentation in the report that it was incompletely removed. That leads to non-retrieval. So this is a slightly different problem. This is where a polyp is documented as removed, but then you don't see it in the pathology reports. And you may say, how does this happen? Well, it does. Sometimes if you're using a biopsy forceps, that little piece of polyp may fall out, and then it gets lost in some of the just normal fluid that's in there, and it may be suctioned and not captured. Sometimes you take a polyp off with a snare and it doesn't stay right where you cut it off. It falls, and sometimes you're doing your scope and you're suctioning, and your technician is saying, hey, I still don't see that polyp in the trap, and maybe it fell further up, maybe it's in a puddle you didn't suck up. Sometimes we just don't catch them, and the motivation to go get them depends. Sometimes if we're pretty sure it's off, we won't spend a tremendous amount of time trying to find them because we just got to keep going with our day. We'll probably have a bunch of them to do. The situation that happens is sometimes the pathology report may say that no polyp tissue is found. And then you're stuck with, okay, now what do I do with this information? Try to break it down for you. If there's only one polyp, the report says it's removed, but then you go to the pathology reports and they can't find it, we can't include that patient because we have no idea what that polyp was. If it was hyperplastic, they would be excluded, right? We can't tell if it's an adenoma, et cetera. This is where it gets kind of tricky. If they take out 2 polyps and one's an adenoma and the other one does not have pathology, that patient is actually eligible. The reason is we have confirmed one adenoma, right? We don't know if the other one is an adenoma or hyperplastic, but that matters not as much. It's sort of similar to the situation we were talking about before. So if you have at least one adenoma, it matters less what the other one is. Now you might say, wait a minute, we don't know if there's high-grade dysplasia, et cetera. In general, the rate of high-grade dysplasia in a polyp less than 10 millimeters is extremely low. There is a question, what if there's no path and the polyp was greater than 10 millimeters? A polyp that's endoscopically documented is greater than 10 millimeters would be excluded before you ever looked at the path, because we're only looking at polyps endoscopically that are less than 10 millimeters. And a good follow-up question is, what if the unknown polyp was tubulovillus? That's another good question. You're right that we don't 100% know if that would be tubulovillus. It's just that the chance that a polyp that's small, that's less than 10 millimeters, actually being a tubulovillus adenoma is actually quite low. So, this is a little bit of hand waving here, but we talked about this as a study committee, and we decided in this very unusual situation where there's one adenoma and you're not so sure about the other one, as long as it's small and otherwise would fit the criteria, we've decided that that patient is eligible. And then the continuation of this, if 3 polyps are removed, and there's definitely 2 adenomas, and the other one has no pathology, that's ineligible for the opposite reason, right? The one we don't know about could be an adenoma, and so we decided that that patient is ineligible. The thing I'll say, we're going over this, we're recording this. Slides are going to be available. At the end of the day, if you've seen all this and you still have a question about what's going on and is this patient really eligible, it is still totally okay to reach out. I'm just trying to present some general guidelines so that maybe a lot of your questions, if not some of your questions, are answered up front from this resource. Other things, atypical polyps. There is a polyp type called a traditional serrated adenoma. These are rare. This is a different kind of polyp. It actually is not a flat polyp. So this is where it's a little bit on a stalk. They typically appear on the right side or the ascending colon. These are thought to have a cancer risk that's higher than a regular sessile serrated adenoma. So if you see serrated adenoma, if it says sessile serrated adenoma, that's okay. But specifically, if there's something called a traditional serrated adenoma, again, very rare, but we see it, that patient would be excluded, and that's in the protocol. And they will call out if it's traditional. So if they just say serrated adenoma or a sessile serrated, those are eligible. We talked about this. Tubulovillous adenomas are excluded. You probably won't see a ton of them because the incidence of tubulovillous features in a polyp that's less than 10 millimeters is very low. Same thing with high-grade dysplasia. Those are excluded, but they're very unlikely. You may see something where they say that there's a hyperplastic polyp, but it has serrated or adenoma features. So it's sort of in between what might be a hyperplastic polyp and an adenoma. We're just going to consider this an adenoma. So if that comes up, again, you're welcome to run it by us, but anything that has features of a serrated polyp or features of an adenoma is just considered to be an adenoma. And then you may see something called a lymphoid aggregate. This is actually not an adenoma and not actually a polyp. So if you see that pathology, you can sort of classify that as, irrelevant. You could have 4 lymphoid aggregates and 1 adenoma, and that, 5 polyps on an endoscopy, but 4 lymphoid aggregates, 1's an adenoma. That patient would be eligible because the lymphoid aggregates just don't count for anything. All right, I know we talked about hyperplastic polyps a lot, but let's keep talking about them. Any number of small sigmoid or rectal hyperplastic polyps are okay. So as long as they're all small, the endoscopist may say that there were 5 of them. They may say there were multiple. That's okay. And that's true if they were removed. So you have pathology for 5 polyps in the rectum and they all say hyperplastic. Or like I said, if the endoscopist just says there were some there and I didn't remove them. So these polyps, small sigmoid and hyperplastic polyps, they leave in, or even a hyperplastic polyp confirmed on path that's further up, do not exclude the patient. And this is on the qualifying colonoscopy, or if they have this finding on prior colonoscopies and otherwise don't have adenomas. Okay. So some things about age and comorbidities. So the protocol was updated. We are now using patients down to the age of 45 from 50. This is consistent with the new guidelines. So now the age is based on the time of the qualifying colonoscopy. So if you're 45 or younger than 70 at the time of your eligible qualifying colonoscopy, you're in. One thing that came up, if your qualifying colonoscopy is when you're a little bit older in this range, and say they're 5, 10-year, maybe they're 5 and their 10-year colonoscopies are after the age of 70, this is okay. They don't have to be planned to have all their subsequent colonoscopies before the age of 70. It's just that their qualifying colonoscopy has to occur before the age of 70. The flip side of that is if at the time of qualifying colonoscopy, they have some other major comorbidity and their life expectancy is less than 10 years. One, you could argue that if it was a screening, they never should have done it. But sometimes patients that have serious comorbidities will get a diagnostic colonoscopy, maybe where a few small polyps are found. But in that case, because we don't think the patient, is going to make it to their surveillance colonoscopies and ultimately the outcome, that patient would not be eligible either. Of course, the flip side is what we just talked about. If they're otherwise a healthy person and their qualifying colonoscopy was at the age of 65 and they're thought to have, greater than 10-year life expectancy, then those are okay because that's a patient who very likely will be able to get their surveillance colonoscopies, meaning their follow-up colonoscopies within the trial. A diagnosis of irritable bowel syndrome or IBS, those patients are eligible. And a diagnosis of microscopic colitis or lymphocytic colitis or collagenous colitis, these are all sort of similar terms. Those patients are eligible. But inflammatory bowel disease, IBD, very similar name, but very important difference. IBD constitutes diagnoses like ulcerative colitis or Crohn's disease. These patients are ineligible. And the reason is that unlike IBS, irritable bowel syndrome, or microscopic colitis, inflammatory bowel disease, ulcerative colitis, Crohn's disease actually increases your colorectal cancer risk. So they are not considered average risk, whereas an IBS, irritable bowel syndrome, or a microscopic colitis patient is considered to be an average risk for colon cancer. So we're about 40 minutes in, but that's actually all of the material that I've prepared ahead of time. So if there are more questions, I'm happy to take them. We talked about this. I agree that we always ask. There are always, despite everyone's very hard work, going to be tricky or unknown situations. We recognize that, unlike me, I assume you guys have not done a couple thousand colonoscopies at this point. And so we are here to help. That's the email address to reach out to if there are any questions. But again, for the purposes of this talk, I will stop and see if there are questions from the audience. And thank you.
Thanks so much, Jeff. We really appreciate your time. Yes, if there are any questions right now, we would love to hear from you. If you want to unmute yourself or pop your questions in the chat, we'll be sure to read them out so that the questions are in the recording. And as always, Dr. Duker said it as well. If you have any questions on protocol eligibility, anything related to that, feel free to reach out to forte@nrgoncology.org. We're more than happy to help. And if there's any tricky situations, we always route them straight to Doctors Duker and Schoen, and they're very prompt to respond and help us out.
And thanks to those who have said it was helpful. That's good to hear. I know that some of you got questions.
And yes, regarding the recording, I see a couple of questions coming through, but to answer the big one, the recording will be made available on the Forte YouTube channel, and the slides will also be posted on CTSU. Give us a few days, of course, to get all of that sorted. And the recording, once it's posted, we'll make the announcement through Forte Fridays as well, and make sure that the link is accessible to everyone working on NRGCC 005. I do see a question.
I see the one about the 68-year-old. I'll answer that. Are the slides going to be available separately? Sure. Okay.
Yes, we will be popping those on CTSU.
Great. So yes, you'll have the slides if you want to download them and review them, or the whole video as well. So the question, which I think was a good one, is if you have an older patient who's 68, who's not healthy, would you recommend not putting the patient in? Yes, I mean, I think what we're considering not healthy is that their life expectancy is less than 10 years. So, some common examples might be, New York Heart Association class 3 or 4 heart failure, other very, very significant comorbidities, advanced COPD, obviously things like cancer, which is an exclusion criteria in of itself. I would recommend not doing that. So if a patient like that is getting a screening colonoscopy, my first head scratching question is, well, wait a minute, why was that indicated? But even if that patient gets a diagnostic colonoscopy for bleeding or another problem, even if they have 1 to 2 tubular adenomas, always something to review, either with us or with the PI. If this patient is just not well and the chances that their 10-year survival is less than 50%, or even lower, that's probably not a good case. So I got a longer question. I'm just going to take a minute to process it. So there's exclusion criteria. Previous malignancies have to be disease-free for 5 or more years and deemed by the physician to be low risk. Yes. Except for skin cancers, basal and squamous cell cancers, these are okay if they're diagnosed and treated within 5 years. So for these types of cancers, should patients already in remission, or can they be eligible if still undergoing treatment? So just clarify, do you mean for patients who have basal and squamous cell cancers? Okay. So yeah, in general, if they have a squamous cell or basal cell carcinoma of the skin, and say last year, and they had that treated, most of the time that's going to be just, completely excised. That would be okay. That would not exclude a patient from participating. That's considered a low risk, thing. Now, if this is a more advanced cancer and the patient's on chemotherapy, I think that would go into, sort of the 5-year protocol. But if they're in situ cancers of basal and squamous cell, there's no, spread, and they're sort of treated completely, that would be okay. And the next question is breast cancer on year 10 of hormone therapy. Yes, I mean, you would have to confirm that the patient was thought to be low risk of recurrence. But as long as the treating oncologist thought that, then I think that patient would be eligible. And I think it's hard because, yes, they're on hormone therapy. However, that's not necessarily like an active treatment as far as I understand. It's a little bit of a gray area, but I think I would probably defer to the oncologist about their risk of recurrence. Obviously, we're looking for people with a low risk of recurrence, to look for people who could develop colon cancer and live long enough, honestly, to develop colon cancer who otherwise have a very, very low risk polyp. There is a question about dialysis. So again, I think this could be tricky. A lot of times if they're on dialysis and they're not a transplant, candidate, then their life expectancy is going to be on the lower side. I don't think that would be a great patient. And then I don't have the whole from memory protocol in mind, but I also think if you've received a transplant and then are on an immunosuppression medication, that subsequently disqualifies you. So kind of no matter what happens, if they stay on dialysis or they get a transplant, I think either way they would not be great candidates. So I would consider dialysis, and I should, when we say dialysis, I mean, either hemodialysis or peritoneal dialysis, just because of the comorbidity associated with that. I don't think I would include them. And again, yes, it'd be great if they got a transplant, but even if they did, they would then go on immunosuppression medication, and then the immunosuppression medication would be a contraindication to being in the study because there's a thought that the immunosuppression might increase your colorectal cancer risk. So sort of either way, I think probably it's wise to stay away from patients on dialysis. Okay, another question. So there was a single polyp in the colonoscopy report. Pathology is a tubular adenoma. Would this patient be eligible? The answer is yes, as long as the single polyp that was documented, there's some size attributed to it, for which we thought was less than 10 millimeters. So obviously, if they listed a size, that would be great, like a specific size. the word small, diminutive, things like that. And if there's any confusing permutation of that, we're happy to help out. Would be allowed. But I think if there's no documentation of the size of the polyp, there's no suggestion of what size it could be, then unfortunately, I think we'd have to exclude the patient because we just don't know if it's greater than 10 millimeters. And as we talked about, using the pathology report as a surrogate for information that's not in the endoscopy report is probably not a good idea, because if it's in sections or it breaks up or they're taking more normal tissue, you can't really estimate. So I think one of the requirements is that a size of the polyp has to be documented in the colonoscopy report in order for us to consider the patient eligible. Another really good question: are sessile serrated lesions and sessile serrated adenomas the same? The answer is yes. So a sessile serrated lesion, or SSL, is essentially considered an SSA, or sessile serrated adenoma. Good. Okay, I think I was going to say these are all very good questions. I'm happy to take more. I'm happy to have you email your questions or clarifications after this is concluded, but I really appreciate all of you being here and interacting and asking these great questions. And we just want to be helpful and help you get patients into the trial. It's been so nice having so many patients already enrolled. It's really amazing. We have a huge requirement to fill, and we're really getting there. And that's because of all of you. So thank you. We had another quick question. If patient had an adenoma on a past report, but we cannot see the report, should we still consent them? This is tricky. So how I would approach this is, because they think they had an adenoma, I would exclude them. Now, yes, it would be great if you could get the report and maybe say, oh, it wasn't an adenoma, it was hyperplastic, so you are eligible. But if the patient remembers the word adenoma and you can't disprove what they think is true, that's not somebody that we think meets eligibility criteria. So they either need to tell you that they had no polyps, or they think they only had hyperplastic polyps, or they were told to come back in 10 years. But if they're saying, I think I had an adenoma, or my doctor said to come back in 5 years, but I'm not sure what I had, that's a little bit more concerning for somebody that actually did have an adenoma. We can't just prove or disprove that, and I would not pursue consenting them. And the next question is, are sessile adenomas allowed on the qualifying colonoscopy but excluded on the history? So yes. Oh, I'm sorry. Why are they allowed on the qualifying? So a sessile adenoma is considered an adenoma. And remember that any adenoma, be it a sessile adenoma or a tubular adenoma, on a prior colonoscopy to the qualifying, excludes you. So if it's your second colonoscopy, but on your first colonoscopy you had any adenoma, you're excluded. And if you have it on your qualifying colonoscopy, that's okay, right? Because it has to be your first colonoscopy that diagnoses a tubular adenoma or a sessile serrated adenoma, or one of each, or two of one kind, right? So really trying to differentiate polyps the first time finding polyps on the qualifying exam, and making sure there's no history of polyps on prior exams. And a sort of a related question: if the patient has a history of a polyp, but it's not specified in their record, would they be ineligible? That is, again, kind of depends on the context. So that could be hyperplastic, could be adenoma. If you can get the report, that's great. If they don't know, then you're kind of in the second level where you're asking them, well, what did they tell you about their polyp? Did they say what kind it was? When did they tell you to come back? If they're not sure and they told you to come back in 5 years, that's a bit of a red flag that it could have been an adenoma. If they said, I had a polyp, but they said, don't worry about it, it's not a precancerous polyp, come back in 10 years, that is much more likely to be a hyperplastic polyp. And I think we're more lenient in that sense, and would like to include them. But if there's really no information, like they don't know if they had a polyp, they don't know when they were told to come back, we just simply don't have enough information to include or exclude them at that point. The next question is a family history of colon cancer with no indicated age of diagnosis. This is a very good question. So we have a requirement in exclusion criteria that if there's a family history of colon cancer in a first-degree relative below the age of 60, that's considered a higher risk person, and they would be ineligible. So if a patient knows they have a history of colon cancer, but there's no age associated with it, you don't know if it's because they had colon cancer when the patient was 50. I'm sorry, when the patient's first-degree relative was 50, that would make them ineligible, or when their first-degree relative was 75, which would make them eligible. But because you can't tell, I think that patient, unfortunately, would be excluded from being a participant. Here's another question. This is about insurance coverage. I'm glad this came up because this is a very, very concerning topic, and I'd like to address it. I have a couple of patients worried about insurance not covering their scopes. How do you suggest we cover the topic with the patient? Can the patient call their insurance? And then of note, if a patient is randomized to a 5-year scope, will we do the 5-year from the last scan or the 5-year from the start of study? So I'm going to answer the last part first. The time points of randomization to the next colonoscopy, the reference is the date of the qualifying colonoscopy. So what we like to say is if a patient had a colonoscopy on January 1st, 2020, the date of and they're in the 5 and 10-year arm, the due date, so to speak, of their 5-year colonoscopy would be January 1st, 2025. So it's not relative to randomization or anything like that, or when they were randomized. It's relevant to when the qualifying colonoscopy occurred. Now, the insurance coverage one is very difficult. The problem with calling the insurance, and you guys know this, if you call the insurance and say, can my patient have something, their first answer is going to be no. And that's just the reality that we live in. Practically, I've been practicing gastroenterologist for a while now. All of these patients, when they come for their FORTE protocol scopes, by definition will have had a prior adenoma. And the indication for the repeat colonoscopy is going to be history of a polyp or history of adenomatous polyp or whatever the case may be, or surveillance is what it's called, more generally. What we've seen practically is that insurance is covering surveillance colonoscopies because the intervals for surveillance colonoscopies vary greatly. And there are some patients undergoing surveillance where the indicated exam is 3 years from their last colonoscopy. Sometimes it's 1 year. So we have not seen insurance really nitpick on the indication being surveillance and then saying, well, wait a minute, the indication is surveillance, but what kind of polyp did they have? And let's get into the woods. We have not really seen them get into that level of detail. And I'm saying just clinically as as a practicing endoscopist who's doing lots of surveillance. So I know there's this concern that, the report says 5 to 7 years, and now we're saying come back in 5 years. But we've discussed this on the leadership level. We've discussed this with our endoscopist steering committee. And the thought is the same, is that if the indication for the repeat scope is surveillance, that has been passing the insurance muster for most people. And the drawback to calling the insurance is insurance by default is just going to tell you no. And in reality, when the push comes to shove and it's actually time for the surveillance scope, we really have not seen an issue. Now, on a large scale, as the trial goes on, I don't have a crystal ball. In 3 years, 5 years, 7 years, is there going to be some sort of crackdown, so to speak, on this? I'm not sure. But so far, we really have not seen that, and we actually don't anticipate seeing that because I think they're really looking at the indication, which is surveillance, and they're really looking to make sure people aren't getting screening colonoscopies, like people that have no polyps, getting colonoscopies, over and over again in less than 10-year intervals. But that's really not our population. Our population all has a polyp. So a bit of a tricky, nuanced answer. It's a great question, but the short version is we're still full steam ahead and have some very good reasons, in my opinion, to believe that insurance will be covering the surveillance scopes because of the way that they're ordered and indicated. Okay. Another question. If a participant is randomized to 5 and 10 and elects to do a colonoscopy 2 years after the consent on their own, would they still be required to do the 5-year follow-up, or would the one that was earlier count? This is a very timely question. So this actually came up at our recent steering committee meeting. I think the short answer is going to be that you'll have to await some further guidance. But the short version is that as a steering committee have decided that colonoscopies that occurred less than 2 years from the qualifying colonoscopy, we're still going to require the 5-year follow-up. But anything after that 2-year time period, we're actually going to count as the 5-year follow-up. So if that seems kind of confusing or crazy now, don't worry. We're going to have that all very clearly mapped out and very clearly communicated. But this question of what to do about what's called unscheduled scopes, right? So for whatever reason, they have some symptoms, whatever the case may be. We're not telling people not to get colonoscopies. If people's doctors, they go to their doctor and they have a problem, they have rectal bleeding, we're not saying, oh, no, you're in FORTE, don't get your colonoscopy. If someone that's treating them thinks they need a colonoscopy, they need to get it. We're just trying to prevent a routine colonoscopy. Say they have no symptoms and the doctor says you're due. Well, wait a minute. We like to make sure, what's going on with FORTE. But long story short, we're trying to actually come up with very clear guidelines on what to do about unscheduled exams that occur before the 5-year interval. And based on how close it was to this 2 years and before versus 2 years and after is actually going to influence the recommendation we give. But that'll be very clearly spelled out in future communications.
We are just about at 3 o'clock. Thank you so much, everyone, for your time. If there are any other final questions, and if Dr. Duger doesn't have something else to run to, we'd be happy to take a final few questions. If not, thank you so much again for all of your effort to randomize patients to Energy CC005. And as always, if you have any further questions or you would like to reach out about anything FORTE related, of course, the email address is forte@energyoncology.org. Thank you again, everyone, for your time, and thank you again, Dr. Duger, for taking the time to present Polyp 101 today.
Happy to do it. Thanks, everyone, for their very, very hard work in this trial. Very, very happy with all of you. Thank you so much. Happy to answer questions. Happy to be here.